So at this ASH in San Diego in 2024, I'm going to present data on the prognostic impact of circulating tumor cells, in short CTC, in transplant-eligible patients at diagnosis treated with the most updated standard of care in the PERSEUS study. Patients at diagnosis present very often with cells in their peripheral blood. We call them circulating tumor cells. And it has been shown in the past that patients with more of these circulating cells do worse in terms of progression-free survival, overall survival. And we know that this is independent of other risk factors, but there's still some open issues and questions in the field. So we don't know if patients receiving the most updated drugs, which include anti-CD38 antibodies, daratumumab, and alone, or in this case in the context of other drugs, so the DVRD regimen, daratumumab, lenalidomide, bortezomib, dexamethasone, transplant and maintenance, would also be affected by this prognostic biomarker. So first, this is the first thing, and then we also don't know how this biomarker affects the impact, so the achievement of MRD negativity, which is the deepest type of response that we can have in myeloma, and it's strongly prognostic as well. We first looked at the impact of circulating tumor cells as a biomarker alone, and we saw that as a continuous variable is strongly prognostic in this context, in this trial. Then we saw that it's also independent of other risk factors as previously described. So what we generally consider as a risk factor is a high-risk cytogenetics, so specific genetic lesions like deletion 17p and specific translocation for 14, 16. And then we also included other established risk factors like ISS, LDH, and CTC were still prognostic when accounting for these other factors. And then we looked at the impact of treatment that is tested in this trial on this biomarker. And we saw that patients that received daratumumab, so DVRD compared to VRD, benefit both if they had high or low circulating tumor cells. And also patients receiving this regimen have higher rates of MRD negativity, regardless of their levels of CTC. And finally, we also noticed that when you combine this biomarker, high-risk CTC and, for example, high-risk cytogenetics, you can find a subgroup of patients that really do worse, like the very dismal prognosis, and that could still represent an unmet need. So I think there's really now a body of data that supports CTC as a strong prognostic biomarker in myeloma, and this data set corroborate these findings. And I think the next step would be really to start to look at this biomarker in clinical trials and clinical practice and include it in the certification of patients, and also understand better its interplay with other risk factors is very important, as I pointed before, for example, with high-risk cytogenetics. But there's still a lot of work to be done, but I think it's time now to really consider this biomarker in the standard risk assessment.